You know, when we hear about cancer, we always hear about stages, right? Stage 1, stage 4. It sounds so simple, like a single number tells you the whole story. But what if I told you that for lung cancer, that number is just the cover of the book? Today, we're going to dive into why a tumor's specific location, literally its address in the body, can matter a whole lot more than its size or even its official stage.
So, let me just ask you straight up. If two different people both have stage 2 lung cancer, should they get the same treatment? I mean, your gut says, yeah, of course. But the real-world clinical answer? It's a hard no. And figuring out why that is, well, it changes everything about how you look at this disease. Just take a look at this. On the left, you've got a small tumor kind of just sitting there in the lung tissue, not bothering anything. A surgeon can probably go in and take that out. Pretty standard stuff. Now look at the right. Same size tumor, but this one is pushed right up against a major airway. All of a sudden, the surgery isn't standard at all. It is ridiculously complex, and the entire treatment plan has to change. Same stage, two totally, wildly different situations.
Okay, so to really get why location is king, we first have to learn the language doctors use to talk about this stuff. It's called the TNM system, and it's basically the secret code behind those stage numbers we all hear.
The TNM system is actually pretty straightforward when you break it down. T is for the main tumor. We're talking its size and if it started to grow into anything nearby. N is for nodes, as in, has the cancer spread to any nearby lymph nodes? And M is for metastasis, has it traveled to distant parts of the body? T, N, and M.
So here's how it works. Each of those letters gets a number. A small tumor that's staying put might be a T1. A really big one that's invading its neighbors is a T4. No cancer in the lymph nodes? That's N0. But if it's spread way over to the other side of the chest, that's an N3. And M0 means no distant spread. M1 means there is. Doctors put all three of these together to come up with that final stage number. But, as we're about to see, the real drama is hiding inside that first letter, T. And this, right here, is where the radiologist becomes the most important detective on the case. They're not just taking a measurement of a tumor. Oh no, they are creating a super detailed map of a very, very dangerous neighborhood.
You don't have to take my word for it. This quote from our source material says it all. The real magic of a radiologist isn't just spitting out a T number. It's about describing exactly what that tumor is touching, what it's threatening, and what that means for the surgeon who has to go in there. It's all about creating a life-saving roadmap. Okay, let's look at a case. Here, the tumor is in just about the worst spot possible. You can see it right there, a mass that has completely choked off the main airway to the top part of the left lung. Everything behind it is collapsed. Now, technically, this is a T2 tumor, but its location is an immediate life-and-death problem. And check this out. This is the amazing solution. Because the radiologist mapped out the problem so perfectly, surgeons could pull off this incredible procedure called a sleeve resection. They literally cut out the bad part of the airway and then stitch the healthy ends back together, almost like tailoring a sleeve on a shirt. And by doing that, they save the patient's entire lung. That only happens when you know the tumor's exact address. Now, let's check out another super high-stakes situation. On the left, you've got a tumor that is just abutting. Basically, it's just leaning up against the aorta, the body's biggest artery. On the right, a different tumor is actively invading the main pulmonary artery. Now, to you and me, they look pretty similar, but to a radiologist and a surgeon, they are worlds apart. And here's why that tiny distinction is everything. Abutment, just touching the vessel, might still be something a surgeon can work with. But invasion, where the cancer has physically grown into the wall of that vessel, that often means the entire lung has to come out in a massive operation called a pneumonectomy. Or worse, it could mean the cancer is completely inoperable. That one little detail on a scan changes a person's whole life.
And believe it or not, it can get even more intense. Here, what we're looking at is a tumor that has grown directly into the wall of the heart itself. That's an automatic T4 cancer. The challenge for a surgeon here is just immense, maybe even needing a heart-lung bypass machine during the operation. Again, it's not the size, it's the address.
Okay, next up, let's look at a really special case that puts the entire medical team to the test. It's called a Pancoast tumor. This is where all the challenges we've been talking about get rolled up into one big, complicated puzzle. So a Pancoast tumor grows at the very, very top of the lung. The best way to think about it is like trying to build a skyscraper in the middle of the most crowded intersection in a city. It is just surrounded by everything important. Major blood vessels, the spine, ribs, and this whole tangled mess of nerves called the brachial plexus. To solve a puzzle like this, you have to use the right tools. So the CT scan on the left, yeah, it shows us the tumor and the bones pretty well. But if you really want to see if it's gotten into all those soft tissues and nerves, you need an MRI. Look at that image on the right. The MRI gives you such a clearer picture. It is the absolute key to figuring out if surgery is even an option. And the stakes are just unbelievably high. Because this location is so tricky, the source material says that less than half of all Penco's tumors can even be considered for surgery when they're first found. Less than half. So we've focused a lot on the T for tumor, but the next step on this roadmap is tracking the N for nodes. Think of the lymphatic system as like a highway system for your body, and unfortunately, cancer cells can use it to travel. Where they get off is another huge decision point for treatment. The logic here is actually really clear. If there's zero spread to the lymph nodes, that's N0, then the patient usually goes right to surgery. If it is spread to some nearby nodes but they're still on the same side as the tumor, N1 or N2, the team might decide to use chemo first, to shrink things down before they operate. But if that cancer has crossed the middle of the chest to nodes on the other side or gone up to the neck, that's N3. The disease is usually considered unresectable, and the whole treatment plan has to pivot away from surgery.
And that brings us to the final letter, M, for metastasis, and one of the trickiest things in all of cancer diagnosis, telling the difference between real cancer spread and things that just look like it. These are called mimics, and they are masters of disguise.
So one of the most common mimics is something called a sarcoid-like reaction. Basically, it's just a big inflammatory response that can happen after certain treatments. The problem is, on a scan, it can look exactly like cancer spreading. But there are clues. Real cancer spread tends to follow a logical path. It's usually uneven. The mimic, on the other hand, can just pop up everywhere, symmetrically. And on a PET scan, active cancer glows super bright, while the mimic often has more of a mild, moderate glow.
Look at this scan. You see all those lit up lymph nodes? That looks terrifying. It looks like the cancer is absolutely everywhere. But in this exact case, they did a biopsy to be sure, and the results came back negative. It wasn't cancer at all. It was that inflammatory mimic, that sarcoid-like reaction. It was just the body's immune system going a little haywire in response to treatment.
And I mean, let's just sit with that for a second. This is why getting this right is so profound. If you mistake that mimic for real metastasis, a patient who could potentially be cured might be told their disease is terminal and get shifted to comfort care. But if you correctly identify the mimic, you keep that person on the path toward a cure. The stakes just don't get any higher.
So what's the big takeaway from all of this? It's that a cancer stage is so much more than a single number. A radiologist report isn't just a measurement, it's a story. It's a detailed, life-saving roadmap that guides the surgeon's hands, the oncologist's decisions, and ultimately, the patient's entire journey. It proves that in this fight, the address almost always matters more than the size.
And that kind of leaves you with one last thought, doesn't it? If a single number, like a cancer stage, can hide so much life-altering complexity, what other numbers do we use every single day in our health, our money, our society, that might also be telling us just a tiny fraction of the real story?